have the pleasure of calling up to the stage Quentin van Rensburg. I didn't prepare a slide on myself. My name is Quentin. I started my career as a dev or a software engineer in retail. It's very exciting because retailers are forever pushing the boundaries, are considered a little bit abrupt and rude because they're forever in your face because they want the consumer to convert, right? But the experience is not generally that personalized. And when I went into healthcare, it kind of felt like I went back 10 years of my life because things are fragmented, there's legacy systems we have to deal with, and when you engage, it has to be personalized, it has to be at the right time, so timing is of the essence, and generally the information shared or the engagement is very confidential. So that was a little bit of a learning there. I work for Platinum Health. Platinum Health is a closed medical scheme. We're an HMO, so we're a funder and a provider of primary healthcare services as well as occupational health or medical surveillance. And that's kind of the start or the journey for a member for us, is us understanding when you go through the mining process or the medical surveillance process and you do your initial, we get your full primary healthcare record right there and then. And that's kind of where you start with us. So that's just a bit about me. I'm the CIO there, and I'm supported by a great team of executives that are also very much pro-tech. So my life is fun every day. Okay, so I suppose the way that I structured this presentation is I'm kind of setting the scene from a provider's perspective. What are the incentives that drives medical insurance? What are the levers that needs to get pulled for us to achieve our objectives? And then, of course, as a member, which I'm sure all of us are, what are our benefits? What are the incentives and the things that we want to see as members, right? Then we're going to look a little bit about AI, and if I lose the audience at that particular point in time, just throw me with something. I am a techie after all. And then in the end, is there any kind of return on investment like Taryn had indicated? That's generally what the number crunchers wants to see in the end, right? Okay, medical schemes and administrators. I made the assumption that for today's presentation, let's assume that they are one entity. Sometimes that is outsourced. Some of the tasks can be outsourced or it can be retained in-house. But for purposes of the presentation, we'll assume that is one entity. Now, generally, and there would be probably funders in here that could argue the numbers, but I use some ranges. At the top, the very blue indicator there is generally considered your non-healthcare expenditure. So for R1 that you get, as a medical scheme, you will spend maybe 10 cents on administration costs, and I'll get into what that means, right? The rest is healthcare costs. Direct healthcare costs, claims, us for paying providers for the services that were rendered. What I did not include here is under non-healthcare costs is things like broker fees, because that could range depending on the kind of arrangements that you have. I also did not include reserves. So medical schemes are regulated by the CMS, the Council for Medical Schemes, to ensure that should there be a high volume of claims at a particular point in time, that the scheme is sustainable and they can carry those kind of expenses and claim costs, right? So for purposes of those, I kept it out of the percentages, but just to give you an indication. So that's kind of the makeup. It's the 90-10% rule. Under membership administration, we look at these fundamental areas where a lot of, let's say, admin is spent and time is spent. So membership onboarding, that's of course a little bit of underwriting work that needs to get done. We need to get you onto the medical scheme system. We need to load beneficiaries. We need to get your welcome packs and your cards printed and all of those kind of nice things. We need to inform you that you're a member and all of that. Authorizations, so you need special treatment or hospitalization, or you need to go and see a specialist. We need to have protocols and processes in place to know that the authorization is correct, it's accurate, it's according to your benefits list, and off you go, right? So we can do the pre-auth and the auth right there. The two bottom ones kind of joined by the HIP claims claims adjudication, applying the right rules, ensuring that the claims are processed accordingly. Time is of the essence because, if you go and see a specialist, it's out-of-pocket payments, you have to do claims, and that's when you start feeling the pain of the inefficiencies that could live within a scheme, right? And then fraud, waste, and abuse is big. Upcoding, it's all respect to GPs, but let's say there's a perceived, let's say the physical treatment had a perceived complexity, they will upcode and they get the benefit of the claim amount right there. So we have to have these mechanisms of detecting fraud, waste and abuse, or FWA, as we know it. Case management kind of runs across all of the three at the bottom. Good case management also very necessary within a medical scheme. Okay, healthcare costs, which then is the majority, the 90% of the contributions that we get, and it is made up of frequency. So we have to have protocols to ensure that when you need the service, that it is appropriate and it is according to either the formulary lists that we have put with our pharma friends, and the benefit limits would apply accurately. And then the cost per encounter, of course. So we have our network out there, DSPs arrangements, Netcare is one of ours, and the arrangements and the tariffs that we pay, is it a cost per capita or whatever the agreement is that is being fulfilled. And ultimately all of that is bundled into a product design. So the design of the plan is then made up, and as the medical scheme then puts it out, that makes up how you consume the service and what your monthly contributions are. Everyone still with me, huh? Okay. Okay, then the members, which I can't point fingers, I must point fingers at myself. The very first one, benefits. So it's the perceived richness in benefits that's always the problem. Because the fact that you pay, and especially in the mining industry, where depending on the salary bands, for somebody that earns, let's say, less than 50,000 Rand before tax, let's say an amount of 2 grand a month, the perception that they can claim or have access to healthcare is that they are fully covered. We expect full cover, I put it there, because that's kind of what all of us have in mind, right? We will go walk in, no out-of-pocket expenses, and we'll walk out and we will receive the service, right? Then access, of course, we expect that our provider or funder has got arrangements to make it healthcare accessible at our convenience. We kind of come with that consumer lens in mind, and we want to service ourselves as and when we need it because it's acute. It's episodical. That's what healthcare is, right? It's never really planned for, unless it's a crown or something like that. Service, yes, now you're consuming the service and you're expecting a pleasant experience. There was not long waiting times or queue lengths. You're being kept up to date around when you will be seen by the doctor. It's kind of there's this running joke, but you would sit for 2 hours in the waiting area only to be seen for 5 minutes, right? But that's kind of how it works. But that perception of, I want the experience to go well, and then of course the price point. So the price point must meet then the benefits and what your expected outcome must be. And then it really only starts becoming real, and I made a note here, is when you consume the service and you start running out of savings and now it's out of pocket expenses, that you start realizing what is that perceived value is now becoming a reality, right? And that's the kind of fine line that us as funders need to deal with. So how do we meet members' expectation, or beneficiaries, or belly buttons, whatever you want to call them, versus what the benefits can provide for the price? Okay, so maybe then to go on a little bit on AI. So now that we've kind of set the scene, who wants what out of this healthcare system, right? The rise of AI. So I kind of want to focus on two quadrants only. So this is the fourth industrial revolution. Just maybe zoning on the first one, connectivity and compute. I've been old enough and around in IT for some time, and I know that, you know, at one point in time, cloud was the buzzword, and everything had to go cloud and so on. And we went through that kind of journey, and we found a middle ground. But I suppose ultimately this interoperability approach really set the stage, because if there are no roads, how will we travel from one point to another? So the kind of foundational or infrastructure work needed to get done. And we have to give credit where it's due. You know, cloud has given us the ability, even as a startup, to start having access to very clever systems, compute, and, you know, just hosting on the drop of a dime, right? So you can get your systems up and running, you can get your practice up and running as early as possible by just leveraging off the technologies there. And then, of course, I mean, right at the bottom there on the right, now that we have digitized, we have cloud, just like Richard said, I mean, I've worked with Richard for many years, just like he said, now that we are consuming information and we're warehousing all of this unstructured data, geez, what do we do with it? Where do we actually even start? I mean, you saw it, data analysts popping up, data governance specialists starting up. What data governance approach are you going to take, or framework, Sebastian's framework, are you going to adopt? So how do you measure quality, for example? How do you normalize data for the model to understand? These things started evolving. It's almost like, and I've got it down here further, but I don't know if you guys follow Neil deGrasse Tyson, which is a physicist, right? And he says the moment we hit one frontier and we've overcome it, there's just a very next frontier that physicists need to try and understand. And okay, now it's, you know, the quantum theory, we've kind of gotten down that route, and now the next frontier, and so we are ever evolving, right? Okay, so don't be alarmed. This is not algebra back in your days. This is just a little bit at the core of AI. What we're seeing is happening. So for a very long time, there was an input, what we call nodes, and there was an output. So for general systems, the moment you punch in something, you expect some sort of result, right? And we've seen the innovation across all of these spheres in a AI model. Now, this is very much done on a neural AI model, which is kind of on the deep learning side of things, right? So you've got inputs, and that could be anything like demographics, the amount of claims that you have, the type of claims that you have, the diagnosis codes, any inputs that we feel we want a predictive output to happen, right? And it's weighted according to perhaps importance or impact or influence. There's a little bit of sum that happens, or calculation that happens. Bias is generally external information. The model needs context, right? It needs to understand the industry, needs to understand seasonality, all that kind of stuff. And then something that's been lacking in AI for a while, I suppose, when machine learning kind of just evolved, is the decision making, which is nothing else but called a function, where it had to make a decision based on the best predictable outcome. Now that we saw through deep learning, which is made out of two aspects, and they call it supervised or unsupervised approaches. A supervised approach means that it's structured data, which is labeled, that goes through this model, and at a point in time, depending on what the labels are found, it will give you a labeled output. Then you get unsupervised or unstructured. There's no need for data governance and that kind of stuff to happen. You can give it and feed it unstructured data, unlabeled, and it will give you approximate based on themes, patterns it's picking up. It's almost asking ChatGPT to give you an image of a dog, right? It goes and creates the dog, not on elements that it picks up. It creates a theme or patterns, and it creates its own. It's kind of new data that is being created, right? And that's kind of the area where we see a lot of innovation happening. And then outputs. Now, if I had to pull this thing out, and I'm sure if you had to Google the specific word, and I want to give it to you if you wanted to do it, it's called ANN, or artificial neural networks. It kind of expands and it creates a lot of outputs to a lot of functions, to a lot of activation functions, to a lot of outputs. And that becomes kind of the human brain. A lot of neural functions happening, a lot of calculations and things that are being perceived and taken into consideration for the best outcome, which is fantastic. And that's kind of where we are evolving. I hope I'm still keeping the room here. Okay, so this is just my personal journey, right? Personal journey. I came from very much systems development. People wanted to digital transform. I was part of the Netcare journey at that point in time. We had to find means and ways to transform the business because we couldn't work off paper anymore, right? It's inefficient. It costs a lot of money. We have to employ staff. It sits on the bottom line. You know how salaries goes when you start talking to CFOs and HR managers, right? So we got to digital transform. But as we adopt systems, we create, and Taryn might support me here, we kind of create technical debt in the business because we have transformed something into a digital asset. But this asset needs a little babying, right? It's not going to look after itself. So we're generating data, so you have to adopt a strict and strong data lifecycle management. That means the extraction or data engineering. We have to still apply data governance rules. You have to have data warehousing strategies in place. And then only can analytics and predictive insights really start taking shape. And then the very last one, which I probably should have made red, is cyber crime, cyber security. So if data is the new oil, everyone wants access to it, right? And we have to forever think about the moment you employ something, whether it's in your public cloud or your private cloud or on-prem, you have to think about your controls you have in place in your IT security framework and whether that's covered in either your policies or your procedures. And we are very great to innovate, but we never think about the holes that we leave for us to be exposed. And before we know it, this is a thing that's running ransom that's kind of a pun, but ransomware is running ransom amongst our peers. I mean, my neighbors, which is our clients, are being cybercrimed or attacked, which means there could be supply chain, they call it supply chain attacks, can come through integration points, and if we don't have the mechanisms of picking unusual behavior in our network, we are affected by it. So if there are large encryption happening on a database, I kind of want to know about it. So immediately, those are the kind of alerts that we set up to deal with this, let's say, rise in AI and digital innovation that's happening in business. I'm not going to spend much time on it. It's just purposes of the pack. I believe it's going to be shared with everyone anyway. But if you needed to go onto the journey of implementing AI, much like the Agile framework, start with business requirements, understanding where are you going, what is the target, what do we want to hit, and then it just kind of goes through the project life cycle, whether that is a waterfall approach or Agile, however you want to adopt it. But there are means and ways of really implementing it with success. Okay, now that we've spoken about what drives medical schemes, what members want out of it, and what AI is at its core and principles, is it really worth our while? Should we even worry about it, right? So I kind of, as an anchor slide, I put this together. Can AI address inefficiencies on the membership and administrative side? So that's kind of the 10%, right? Can it help us with healthcare costs? So that's the 90%. Is there an opportunity there? And ultimately, even if we address all of those things, would our members be happy with any of the outcomes that it pertains? I didn't put references here, but please, I've got it on my notes if you really want them, but they are on Google Scholar, so feel free. Omega Healthcare, they process 250 million scheme administration tasks, medical billing, and claim submissions. That's annually. That is a lot. I can tell you that. They have improved claims turnaround times by 50%, right? By implementing, and I suppose it's a journey. It didn't happen overnight. And they reduced documentation tasks by 40%, right? So generally, documentation is a tricky one. I'm sure everyone here runs either Teams or SharePoint, and IT is forever asking you to label your data, please. we need the metadata, we don't know what type of document this is, we can start automating that. It can be scanned, it can be filed, it can be classified. If anybody here, again, my head of IT sitting there, Taryn, she would have an appreciation again. We kind of want to have information labeled sensitive or not sensitive, because as part of your cybersecurity approach, you need to have a data loss program in place. And it needs to know that this sensitive data can or cannot leave your organization, can or cannot be shared per department, and is contained well, right? 99% of claims are autonomously adjudicated. So I've told you about when claims come in, there are certain rules per your benefit structure. So per product that you have compiled, we want to adjudicate that to make sure that we are authorizing the right claims at the right time as efficiently as possible. They hit the 99% mark, which is fantastic. Additionally, they said they didn't have to, and it sounds harsh, they didn't have to add any further headcount on getting these things processed. I want to get the acronym right here, but Department of International Studies and Education collaborated with the AI Center of Excellence, and they said over a 25-year span data, if we had to create models, and they've definitely made mention of a hybrid approach, so they took labeled, unlabeled approach, and they said, let's see if we can find a way to reduce on average, which is, I suppose, the maximum is about 10% of fraudulent cases. How far can we drive this model or these models to get it down to zero? And they achieved that. I think it took them 18 months. There were some constraints though. They had problems with data being a little bit unstructured, and there was not enough identifiers to either place it in accordance to the kind of category, the kind of model it needs. So there were some challenges, but over time they overcame that, and they got it down to zero. Okay, so let's bring it a little bit closer to home. So Platinum Health, without giving away my game plan, we are certainly on the AI trend, right? We are on that train. And what are we doing? So we've got a little bit of a problem. We work with the mines, and the HR departments kind of hand over the list of insurers that you can be part of, right? So the moment you form part of Platinum Health and you've now filled in the form, which we also want to digitize, we need to get that member through our underwriting process. He needs to do his medical at the mine, and we need to get you on our medical scheme administration system as soon as possible. The problem is there's a time lapse. So you filled in the form, and then the very next day the guy rocks up at one of our facilities, says, yes, I'm a member, I would like to see a doctor. Now our systems haven't been updated. It's probably sitting in the queue there at administration. So we want to digitize, and we are busy implementing this. We take it in any format, any form or function, and we drive that process. We get the medical done, and we do underwriting on you, and we do also based on the risk or the disease burden that we perceive you will have on the scheme. We will project the risk versus the contributions that we get, what generally is referred to the claims loss ratio, and we start predicting whether you should be forming part of a managed care program. When I go further down, you'll see I've broken that up into tiers, but we want to know that up front, not when you start consuming the service, you've become so complex and you are what we call unsuppressed. So now you've got chronic condition number one, you're unsuppressed, you start getting complexities. Chronic condition number two, you've got underlying comorbidities, and you are costing the scheme a lot of money. Now, if you had to ask me why healthcare costs are going so high, it's because of us as beneficiaries or members leaving it up until the last point, until it really becomes complicated. Then we consume overutilization of the services, and it pushes up healthcare inflation. That's why it's generally annually, it's double the amount of general inflation. It's just because of user behavior, right? So these are the things that we definitely want to look at. We want to get you on our system as quickly as possible, get you on a program. I'll maybe get to that, to the other point of conversion. I sat at the CSIR conference where Dion Kotze, he's the Discovery Commercial Chief, and he showed us very nicely how he can predict pathways for people to follow. The problem is people do not want to follow the pathway. They still have a messaging and an engagement problem. So they've hit that frontier. Just like physicists, they've hit the frontier where they've solved the particular problem, but they can't get the person to convert, right? Claims adjudication, very big on our radar. We want to ensure we're sitting at an engine that can apply adjudication rules, 70,000 of them. So we pretty much have this under control, and we want to make sure that claims are processed efficiently. And there's always an incentive with the provider. So if a Netcare gives us a claim and they're asking for remittance, we can process those claims and get, there's a commercial incentive for us to be efficient as well. All right. Another one, so this is a tangible one that we're feeling. We are on track of hitting an 81% fraud, waste and abuse controls and procedures that we've automated through our systems, right? So that just means that the kind of case management that we do, the auditing and the analytics that we apply on fraud, waste and abuse rules is actually starting to reap some benefits. So it's paying for itself, which is a great thing. Case management, very important. It will talk to the next slide when I get to healthcare expenditure. But case management really gets involved when, let's say, somebody was in ICU, starting to cost the scheme quite a lot of money, right? And we want to see how best we can get, although applying the best care, get a step-down facility, or can there be home care provided, that kind of thing, where this doesn't run away with itself, because generally the formula in health insurance is the young carry the old, the healthy carry the ill, and it's cross-subsidization. Some products or plans are not that sustainable, and others are very sustainable, and they carry themselves, and you kind of don't want to go into the surplus where the surplus needs to carry the scheme as well. That reserves that I was speaking about, that needs to be contained separately, right? And that's why the CMS is very strict on that consumption. Okay, so we've done the automated underwriting. We know which program you need to fall into. It's kind of the tiers that we look, the healthy, generally wellness programs. We want to, like the vitalities and so on, we want to make sure that, you do your 5K run and you get your steps in and all of those good stuff, right? When there's low risk but potential, we kind of want to do preventative care, right? We want to see where we need to engage. And this is kind of where the omni-channel, I don't want to sound like a retailer now, but they have certainly gotten it right. They know how to engage with you. They know how to communicate, your preferred communication method, and they know when you're going to convert. You're in the market for, I don't know, a brand new vehicle. They kind of know it before you know it. And they are forever punting marketing information to you so the conversion can happen, right? So we want to do a very similar approach here. And then we start going into the higher tiers. And you'll see approximates, the 5% of the members cost you about 80% of your healthcare costs, because they are on the unsuppressed and very high-risk areas. That's generally how it works. So this is the area where you really want to focus on to manage, along with case management, right? There's a lot of potential there, but that's kind of when you want to hone in on to keep people suppressed, keep them healthy, and drive them down this model if possible. Then ultimately, us as members, what do we want? And I don't want to sound like a broken record because Richard stole our thunder, but having people access to their own health records, it's kind of empowering the patient to take control of their own health care. That's what it is. And you don't want to sit with it until you have toothache, until that cavity is on the nerve. Then you want to go and see somebody. Maybe you should go for a checkup every 6 months. Then you can avoid that kind of thing. Access to care, streamlined digital transactions. So if you do submit a claim, you kind of want to expect it to happen as quickly as possible. And then, of course, with optimized operational efficiencies, you'll get the benefit of funders. You heard Richard as a provider. If everyone starts getting efficient at what they're doing, it will bring the costs down because the demand is exceeding the supply, and that's why the price is going up. Thank you very much. That's me.
My question is on the member self-service portals. What is the adoption rate amongst your members? And if there are any challenges in terms of adoption, what strategies do you deploy to try and improve the adoption rates? Thank you.
Yeah, so because we're in mining, our demographic is a challenge. We have to understand what channels are most effective. We have launched many features and engagement strategies via WhatsApp. I sat in a presentation, I think it was middle of last year, with Meta, Facebook, and WhatsApp, where they presented us the uptake on WhatsApp, right? And look, every channel has its place. Sometimes you want something emailed to you because you know you're going to store it for a while, right? So you're going to leave it there in your Gmail or whatever. But when you want instant access to, I want to see a doctor now, or I want my membership card, because we're forever printing membership cards. If they're like me, they lose their wallet all the time. Then that card is lost. Now, to get the card to you is an absolute administrative burden. So we've digitized that. So we got our WhatsApp channel, you can ask for it. So WhatsApp really works well there. But it has its limitations when you want to start presenting a lot of information and the real estate is the size of the phone, right? Then you kind of want to expand that, especially on WhatsApp that's very much text-based, right? You could download info guides and so on, but that's not the most optimum way. So there are places for, if you want to see your health record, that's why the app, especially in NRC, in my tenure spending there, that's why the uptake was so great, because just that needle showing you where you are performing, it's just a fantastic way of showing you where the risk is, right? Uptake on our side, we've seen over our beneficiary list, we went from, when we launched, was about 2%. We didn't really throw marketing at it. And when we really started punting, we saw a 10% uptake. So, and that's within a question of about 12 months. So we just need to boast at it. What we are building at the moment is a mobile app. I come from the software space, so we don't generally license things, we build things, right? And then we're in control of the feature set, we're in control of the look and feel, how the journeys are, right? If something is streamlined and it works sexy, people will utilize it, right? I'm very keen on how that journey needs to look like. You don't want to be 10 clicks away from what you're looking for. You kind of want to hit it right there and then. Then the call to action is quite quick. So that's kind of what we've seen in the mining space. On Netcare's side, I'm sure Richard can give you those stats on his behalf. Yeah.
Thanks. So since we see the emergence of AI in trying to solve some of these problems, have you maybe thought of using AI to try and also have different languages? Your apps maybe being the user interface using different languages, because you said you are in the mining space, and I'm not sure about the literacy in terms of your customers, but I take it that there might be some of them that are not really that literate. And have you ever considered using different languages, if I can say maybe, except English? Have you ever considered different languages to try and improve adoption as well?
Yeah, so the South African context is, it's an interesting one. In my previous life, what we had to do is we had to take patient feedback and we had to try and send it through a sentiment analysis API, and then it will give you, based on your criteria that you set, I mean, you set negative connotation, you set positive connotation, and then it reports back, and over time you have an aggregate of the performance per facility, hospital, clinic, person, whomever was involved, right? The South African context is we slang like nobody's business. So we don't use one particular language. We use a combination of Sepedi with English, and there's a little bit of Afrikaans in there. And now the model has to be trained on all these kind of different factors. And depending on which region, I mean, like the Mokopane area is very much a Pedi area, right? So we got to make provision for that. And then you move around and now you're at Xhosa, or we in KZN where it's very predominantly Zulu. So we had to go and find that, look, we didn't solve every single problem. That's why I like the software engineering approach, because it's iterative. Over time, we will certainly get, but there's value on the next horizon. On our next release, which is in 2 weeks, we run sprints and we release value. So we've had our fair share of that complexities, but yeah, we've definitely done a little bit of it.